our OrHIMA webinar, Hot Topics and Current Trends, HIPAA Update 21st Century Cure Acts. Our speaker for today is Kelly McLendon. I would like to introduce you all to Kelly. Kelly McLendon had been a HIM practitioner for over 43 years, possessing not only a HIM credential, but also one of privacy and security of electronic healthcare records, a specialization he had held for as long as those concepts had existed. In 2015, OrHIMA awarded him their Innovator Triumph Award, among numerous major industry other awards over the years. He is a sought-after author and speaker on subjects related to HIPAA and other industry privacy and security topics. Kelly is the founder of CompliancePro Solutions, where he helped design and bring to market a software product called CompliancePro Health, which manage HIPAA and many other areas of compliance. Now he is working with Inzon to continue to grow the CompliancePro brand. Welcome, Kelly. I would like to take over.
Well, thank you. I appreciate it. Everyone hear me okay here? Okay, good. All right, so let's get rolling. So appreciate the introduction. I want to say hello to all my friends and peers out in Oregon. It's been a long time, relatively speaking, since I've been out to Oregon, and my wife and I certainly missed our visit, so we'll have to come again sometime soon. I did sell my company, CompliancePro Solutions, to a company called Genzion, which is a healthcare IT company as well, and it made a good fit and some good sense. So while I did sell my company, we're a wholly owned subsidiary, and I continue on working just as hard as ever and be doing that for a while. So anyway, with that, let's get started because we do have a lot of material to cover. We're going to talk hot topics and current trends, going to talk a little bit about the expected HIPAA update, but also the 21st Century Cures Act. And I'm going to say this on the front end. The more I learn about the Cures Act, the more questions I have and answers that I don't necessarily have. So part of this presentation is telling you what we know, but how it's going to be expressed in the marketplace, what's going to actually happen over the next year or two as it all implements is hard to say. And I'll identify areas where I'm not real sure of some of the answers. If you all know, let me know. I'm going to try to get through the slides in about 50 minutes. Leave us a few minutes at the end for questions and answers. Happy if you want to put questions into chat, or you can just ask at the end. Either way will be fine, but I won't mess with chat till we actually get there. Here's the agenda. I've given you the slide deck. As always with me, my slides are very dense with material, and I won't necessarily read the slides here as we go through. I'll more talk about them, but if you want details, please go back to the slides and look. I take a lot of care in trying to give you plenty of information in the slides, including at times links. So this slide, for example, has a link at the bottom. It's to the article that I actually read the other day that talked about Tefka. I guess that's how we pronounce it. It has been implemented. Those new rules have come out, and that's at the bottom, the link on where I found it. Rama on Healthcare is Rama's a friend of mine, actually, that for years and years now has been putting together that newsletter. I find it very useful for watching for rules to drop and things like that. They'll have articles on that. Anyway, ONC, the National Coordinator of Health IT, ONC, has been working with HHS for 5 years making this new rule. And the rule is really the trusted exchange framework and common agreement. It's not so much of a rule as I guess it is, but it really is about 77 pages long and probably 50 or so pages is really an agreement. So it's a sample agreement uh, that the government is kind of blessed that health information networks can use to structure their network exchanges around. And that's what it's for. It's anticipated to be an interoperability, part of an interoperability framework where you need a trust agreement or agreements between two or more parties that are going to comprise a health information network, or I guess a health information exchange. And this could be the basis of the agreement. So it is a very useful piece, but it's also very specific. You're going to need to have that if you are going to be an HIN or a HIE, something like this. I believe you're going to have your compliance folks and probably your attorneys involved in that exercise. But did want to let you know that that has come out as of, I believe, last week. The HIPAA notice of proposed rulemaking that came out last year, not a peep on it that I know of. Haven't heard anything from any of my connections on when we might get the final rules at this, but we do know that the HIPAA NPRM's intention is to synchronize HIPAA more so with the 21st Century Cures Act, and that the 21st Century Cures Act carries its own enforcement mechanisms. So now we're going to have increased compliance, not just because HIPAA is issuing new rules, but also because they're interacting with other rules like the CARES Act, CARES Act, and the CARES Act too, because the CARES Act actually had some 42 CFR in there, and substance abuse, and that interacts and synchronizes with HIPAA. So really kind of messy as far as how many rules there are out there and how they're going to interact with each other. They pushed the comment period out May 6th of last year. Then we haven't heard anything. And I suppose some of that is administration changes. So the NPRM was put out by the Trump administration. Now Biden's administration has to go through it. But it is curious that it's taking so long to get the HIPAA out. What's in there that we're worried about? Actually, quite a bit. This is going to be the biggest change since 2013 with Omnibus. Once it comes out, if it comes out, the final rules for HIPAA comes out the way that we think they will and what way they talked about in the notice of proposed rulemaking, you're going to have to go in and take a look at your privacy notices. Don't know if business associate agreements will be impacted, but the privacy notices will. And other things. So strengthening individuals' rights to inspect their PHI in person, including allowing them to come in and capture images of their PHI. That's interesting, right? I mean, those of us, I had somebody ask me about that the other day, and I said, well, those of us that have to control PHI is, not something that we're used to allowing, but, we'll figure out a process for if we have to. Shortening the response time on a request for information from 30 days to 15 days, that's a big change. So if that happens, it's paving the way, because we think the information blocking exceptions, you have to apply them within some reasonable period of time, maybe 10 days, maybe a little bit longer than that, depending on the exception under the Cures Act. So 15 days from HIPAA is more or less in line with what we're hearing from the Cures Act. Clarifying the form and format required for responding to individual requests for the PHI. We need to know that, as individuals request electronic copies of PHI, which is what this is all about, really not paper copies, but electronic copies, is, what form and format you have to respond in. We know some of that from high tech, but really we could always have had more details. Hopefully we'll have more details with the new rules. Reduce identity verification burden on individuals accessing their rights. So we've always been tight and try hard not to allow any PHI out. And in fact, sometimes we probably went too far with that, made it hard for patients to get access to their information. At least that's what the government thinks. So they're going to reduce the identification burden on individuals seeking access to their information. Some of that will come in through the use of the APIs and the automatic processes. But again, that'll be interesting to see how that impacts our processes that we have out there. Create a pathway for individuals to direct sharing of PHI among providers and health plans, and also then having those health plans or providers forward the individual's information. All of that gets into details. I'm not going to try to explain it all here, but basically allowing a patient to say, forward my information to someone, and then it could be forwarded on from there. And we are, again, talking more about the providers and the payers. The question always comes up, what about the attorneys and release of information? That's still going to be a problem, but we may have some more ammunition in keeping that problem in control with these new rules. I hope so. They saying things like limiting individual right of access to direct transmission of PHI to a third party to electronic copies of PHI and EHR. So, they're not necessarily trying to provide all of the designated record set out of the EHR if you're directly transmitting copies at a patient's request. So that's going to be something that we can use with the lawyers, I think. But again, we have to see if these come through into the final rules, specifying when electronic PHI has to be provided at no charge, amending permissible fee structure for responding for requests if somebody's directing you to send records out, requiring covered entities to post estimated fee schedules on their websites for access and disclosures with an individual's valid authorization. So, are we going to have to then post release of information charges? I'm not sure. We're going to have to see where it goes in the final rules. But you can see from what we're talking about that there's a lot here, that things are changing in HIPAA. Creating an exception to minimum necessary for individual level care coordination and case management probably makes sense, really, because if you're doing care coordination and case management, minimum necessary, that's something akin to treatment, which really doesn't have minimum necessary applied to it. So that may not be that scary what that is, but it does look like a major change, but I think it's going to be fairly point specific. I'm not going to read all the rest of these bullets. I'm just kind of looking at the blue ones here that I thought were a little more worthy of attention here in our limited time frame. But eliminate the requirement for an individual's written acknowledgement of receipt of a notice of privacy practices. Yay, that the directive, I won't call it what I would like to, where we had to get signatures on a form that we gave somebody an NPP or offered it to them, notice of privacy practices, that's going to go bye-bye. So they're going to say that's a reduction in administrative burden, and they're going to count that as a plus factor. But it is a reduction in administrative burden, and we would like to see it go away. So that's probably going to happen. Modifying content requirements in the NPP to clarify for individuals' rights with respect to PHI and how to exercise those rights. So with the Cures Act, with now electronic records, with electronic health information being derived and grabbed maybe by APIs and sent out automatically, there's going to be changes to your notice of privacy practices. So they're basically telling you that. And it's something you're going to have to go through the document and clarify. And that's probably a time to talk about the patient portal, web access to information, can patients direct copies, places, things like that. So there's a lot there that we will have to get the fine-tooth comb out for the notice of privacy practices. Okay, so that's HIPAA. That's what's coming from HIPAA when we don't know. And will all those things be included, and what will they look like in the final rule? We don't know. All right, let's move over to the 21st Century Cures Act. So the ONC information blocking and CMS interoperability and patient access rules are two sets of rules that work with the Cures Act. They started implementing April 6th of 2021, some aspects even earlier than that. They continue through at least December 31st of this year and probably a year on past that. I don't know how long they'll have enforcement discretion. We'll talk about enforcement soon. Um, but the patient access APIs by certified EHRs for the USCDI, that's a data set that I'll talk about later in this presentation. Those rules implement May 1st, 2022 with 3 months of enforcement discretion, meaning they're not going to enforce on you if you don't actually implement on May 1st, but by August 1st, probably ought to have them in place. The different rules, and if you try to get into reading these things, unless you're an EHR vendor, don't worry about the Part 170 of the information blocking. That's more for the EHR vendors because they're having to get certified that they have APIs that do exporting of EHR materials. But here are the rest of the rules, and the CMS rule alone probably has a dozen attributes to it. It's very complicated. And how does CMS rules, which really are for payers, but also health information networks and exchanges, does that also mean providers? That's a good question. Might have to ask your attorney. 21st Century Cures Act rules again. Really, what they're trying to do is put the patient at the center of the care and allow exchange of their information, not only from the patient to the other parties, like the providers, the payers, the policymakers, and that's spurred by healthcare IT developers, but also that the patient can direct these other parties to send information places, and then can the providers of care request information for themselves? Can the payers do that? And all of that's covered by the information blocking rules, as long as it's electronic copies we're talking about of patient information. The answer is yes. So there is a very wide scope to the Cures Act, but it is surrounded by the patient. Cures Act is not really applicable to attorneys trying to get copies of records that are certified for their court work. They can get copies. The patient can direct copies go to the attorneys, but those are electronic copies. They're at this point what's contained in the USCDI. But it may not serve for release of information purposes. So we've got to figure out for ourselves, and it's going to just fall on us like it does, how much of the Cures Act is going to apply to your release of information processes, and where does it apply? Because it doesn't apply across the board to the release of information processes, but it does apply where patient access is involved. OIG, Office Inspector General, who is enforcing for ONC because ONC doesn't have an enforcement arm, has a website put up already. So you can complain about information blocking already. And there already have been some complaints lodged. They don't publish the numbers that I know of. So we haven't necessarily seen how many complaints have come in yet. But they're apparently not enforcing out of that yet because we have seen no real enforcement action. What we are very curious about in the Cures Act is understanding more and seeing how they're expressed by the EHR vendors, or what called the patient access APIs, application programmer interfaces. Those are calls that can be made through a HL7 FHIR interface into an EHR system, eventually be more than EHR systems. We'll talk about that in a minute, and ask them to provide an export of patient data. How and what formats that will come in? Is the data going to be formatted to be read in another EHR, so it's discrete data? Are there going to be PDFs associated with it? We're really not sure. We're going to have to see how the vendors play with this. There are strict rules that the vendors, in order to have a certified EHR, must be able to provide the APIs in a directory and then provide those exports. really not sure yet what the form and format of the exports are. Each vendor will be a little different. They will have to provide information on their export and their formats. But, you know, how is it going to be done? We're not sure. In reality, how it will look. Also interesting that you can request a single patient's information be exported, or you can suggest ask for a whole population of patients to be exported. So if you were going to change from one EHR to another, there should be an output file developed for all the patients in the original host EHR that can then be output and then be adopted into another EHR. So the records will transfer. How that works and seeing that done, that will be interesting to watch as time goes forward. And again, now it's about going into records and having an export sent out. There is no plan at this point to write any data back into the patient's record. It's a request and a granting of a request, if you will. It's not a request to make changes, or although we are working with HL7, I've done a little bit of work on amendment request HL7s, but I'm not trying to confuse you. That's not what the Cures Act is about. It's about copies out or data out, but not writing it back in again. So there's a big question, and I sit on a committee with OrHIMA, the Electronic Health Record Association, and AMIA, the Medical Informatics Docs, a lot of really good, smart people in that group. And we've been wrestling with the designated record set, which is defined under HIPAA, basically as the medical and the billing records. But now, you know, the designated record set is being used to describe what information is available to be sent out through the APIs. And, you know, part of the designated record set's in the EHR, but the EHR may not have all of the designated record set. You may have changed off a system and still have data in a legacy system or an archival system. You may have scanned images in that are part of the designated record set. So when and how that gets shared, when is really by October, I think 26th of 2022, close to that date anyway. They're going to be increasing what is required under these rules to be shared from the USCDI to the entire designated record set. And we're going to talk a little bit about the USCDI in a minute. So, you know, don't worry, I'll tell you about that. But the question is, what format and how are we going to get APIs on non-EHR systems? Some vendors are building that now, but we have to be careful about understanding this. Most hospitals and larger institutions have been working for a while with their EHR vendors on this, but the EHR vendor is not just the only answer. There's more to be gathered upon request to present the entire designated record set than simply data coming from the EHR system. This is a definition of the designated record set. I'm not going to get into it a lot, but it is important to understand that this is an underpinning in the ONC rules. And ONC has said as much that they are piggybacking on HIPAA rules, yet ONC doesn't necessarily have control of the HIPAA rules or the definitions thereof. So it's two agencies working together. It's not going to be that easy or smooth, but they are, you know, it's a reasonable basis. It can be understood. It's just a complex set of requirements. And again, I'm not here to confuse you and make you afraid, but, you know, trying to shed some light on this complex scenario that's going to take us a while to sort out. It really is. Don't feel like the Lone Ranger if you are having trouble understanding. So now we have a new acronym under the ONC It's called Electronic Health Information, EHI. So you have HIPAA's PHI, but the EHI is what you call the information you're exporting under the Cures Act, maybe through the APIs. That's called EHI once it leaves and exports out. The reason for that is because it was PHI when it was in your EHR system, because HIPAA applies to your EHR system. When you export data from your EHR system to some other system that may be HIPAA covered or may not be HIPAA covered. So what would be HIPAA covered? Exporting into another EHR, HIPAA system to HIPAA system. Exporting to a health app on the patient's phone. That's unless it's an app sponsored by a covered entity, that's not going to be a HIPAA covered app. So you can't really call the information that goes to the mobile health app PHI because they're not HIPAA over there. Now we call it EHI. So the moment it exports, it's EHI. They don't use the acronym PHI in the information blocking rules. They use the acronym EHI. And again, you see it says it supports export for a single patient or export of an entire universe of patients. So it's a new acronym to get used to. Try not to let it confuse you. What it really means is PHI, but it might no longer be managed by a HIPAA entity. The government thinks that if someone uses API from an EHR, let's just say from an EHR vendor, to gather information, get an export, they request an export of Kelly McClendon's information from an EHR vendor. The government doesn't think that that's going to be very dangerous security-wise if they're using the certified API technology, because inside the FHIR interfaces, there are tools like OAuth, it's called OAuth, and some other things that hopefully will meet the security concerns for authentication and giving up the information through the API. There's a certain amount of vetting or verifying you can do on those applications. We're going to talk about that in another slide, but you are supposedly, when somebody's making a request through an API for information, not as concerned about the security because it's been automated with this API technology. I'm not making a commentary on that. I'm just telling you what I read. So, patient education. Excuse me. Here. Make sure that I don't lose my voice. Patient education, whether a mobile health or other type of health app, I just call them mobile health apps. They may not be mobile. They may be on a computer or some other device that's not mobile. But anyway, how do you know if an application that's asking for information through these APIs is a HIPAA entity? Well, it goes further than that. What if a patient asks you about specific applications and whether they're compliant or whether they're safe and secure? There are rules, especially in the CMS rules, for what you can say to the patients about these other apps that may be getting their information that may not be HIPAA compliant. They may be, they may not. But you can't prevent, under any circumstances, an individual from deciding to provide their EHI to any mobile health or other app or developer or company. The patient wants to do it. They have a right to do it. You can't block them unless you think there's a realistic privacy or security or one of 6 other exceptions that we'll talk about. Your education to the patients has to be consistent, focused, accurate, unbiased, objective, and non-discriminatory. In order for it to be that, you're going to have to script those interactions. You're going to have to say, patient brings up system X, this is what we can say. If it's system Y, which we endorse as a health system, you can say something a little different. You know more about it. System X may or may not be a HIPAA compliant app. That will probably influence what you can say about it, but you can't really denigrate any of the apps that may be getting the patient's EHI at their direction. Can you give some guidance on hygiene and security? Yes, but it has to be consistent, focused, accurate, unbiased, subjective, and non-discriminatory, meaning for different vendors, it needs to be basically the same, even though there are some subtleties there. I did with Debbie Primo, who many of you know very well. We did a presentation for CHIA down in California on this patient education vetting. We did a whole hour. So it's a hard part, something you need to be working on now as a part of your compliance program to meet with the Cures Act stuff, and be careful because, you know, which of the rules from CMS apply to a provider? I don't know for sure. I just typically look at all the rules and try to figure out a model that will comply with all. So there's, just to kind of illustrate the complexity, you've got vetting of apps, verifying of apps, and a testing of the apps from third parties. And this slide kind of gets into it. I'm not going to digress and cause us difficulty and to take too much time. But again, in the patient education area for these mobile or these apps that may be taking the patient's information in, you're going to have to be very careful what you say about them and what you can't really recommend unless it's one of the apps from your organization. And even then, you can't be discriminatory towards that app versus other apps. You can be more matter of fact about it. And some of the apps, you can get more information about them because if they're a HIPAA app, you have a right to ask some security questions. But again, it's a very complex area of the law that we're going to obviously run into time and time again as patients are asking about these other applications. And you're going to maybe be a little frustrated on how little you can really say about them. But we will try to guide the patients as best we can. What I live in fear of is that the patients won't read their privacy notices. They won't check the box that says they can't sell or give away their information. Patients going to have non-HIPAA apps that are then going to do whatever they please with the information, and the information is going to get out beyond that app. So that's what I fear. I think because they're not HIPAA apps, a lot of them that we have to be, cognizant of that. I don't know there's anything we can do about it, but we certainly need to be cognizant that patient PHI becomes EHI and goes to non-HIPAA apps. Who knows what happens to it after that? Again, CMS puts out a lot of information on patient education, and it says, generally the education must stop at education and awareness or advice. Can't go a lot deeper than that. Here are some educational resources that you might at a minimum be able to give out, general steps somebody can take to protect privacy and security of health information. That's general steps. Factors to consider in selecting a third-party app, importance of understanding security and privacy practices the app has, and overview of which entities are likely to be covered by HIPAA and which ones are not. So those are fairly high-level questions, but there's going to be any number of these apps coming at you, so you'll have to have a plan for how you're going to manage them. I had this as new sheriff in town for the OIG, but there's more than that now. So we don't just have OCR and HIPAA enforcement. Now we've got OIG, Office Inspector General, for the Cures Act, because all can't enforce anything on their own. Department of Justice is always out there for criminal behavior anyway. But the Federal Trade Commission's gotten involved as well. So, we're seeing some new and more enforcement. The Cures Act has not said what the enforcement of not following the information blocking rules are, other than it would be something like substantial. But they have not said what they are, but they have put penalties out for the EHR vendors because they're afraid the EHR vendors would not play nice and would not follow the rules for having their information available through APIs and things like that. They can have up to $1 million per violation And they can stack those violations. So the EHR vendors have, in fact, been forced to abide by these rules. And again, if you're not working with your EHR vendor on how they're implementing the Cures Act and how your processes are going to interact with that, how you're going to comply, what kind of incidents are going to fall out, are you going to have to track those, which is the kind of thing that we do in my software. You're going to have to figure that stuff out. But they haven't yet published for payers and providers. They just say there'll be appropriate disincentives. There's a first sign of enforcement. There was a old Meditech system, and we think it's old. We don't really know the details. It may have not provided a report that had everything that somebody that made a request and an attorney wanted on it. And so they made it information blocking complaint. We do not know whether or not that will be investigated. We do not know if that would come under enforcement of any kind. But we know that there was a complaint made. And we know that because the complainants published their complaint, not because it came out of the OIG complaint pool. But it is a first sign that complaints will be coming, and who knows how that'll go. The Federal Trade Commission put out a notice, which really you should read that as a warning, that they're going to start enforcing their 2009 breach rules for personal health records, which curiously, back in the high-tech days when they envisioned all of this, HIE was envisioned in 2009 with high-tech, and HIPAA made its changes, and they introduced the concept of breach, and it was a risk analysis-based breach, and the Federal Trade Commission copied that type of breach analysis into their rule for personal health records. They've never once used it for enforcement, but they say now they're going to. They're going to because those apps that are not covered by HIPAA, the only enforcement mechanism that could possibly be is Federal Trade Commission or maybe states, of course, but under the federal government, looks like the Federal Trade Commission is going to be it. Unfair and deceptive trade practices. But the thing about FTC is they're not used to doing breach notification or breach investigations based on a single breach, things like that. They've never enforced this rule. Interestingly, the HIPAA breach standard changed in 2013, but it did not change for the Federal Trade Commission. They still use the old format. They can also fine at $43,792 per day for certain things. But again, this is not in the FTC's common wheelhouse because they typically enforce not as many cases. OCR has to investigate, and they could enforce any case, any reported breach. And other cases too, HIPAA violations. But the FTC is not used to that kind of investigations. So we'll see what happens. Let's see. Okay. We're duplicated that slide. Here we go. So now let's talk a little bit about the USCDI. The USCDI's United States Core Data for Interoperability set replaces the Common Clinical Data set. It's a set of health classes and data classes and data elements. It allows for data beyond clinical data, but it started as clinical data. It's a foundation for sharing HI. It's what is required until October 26th of this year, when you will have to comply with exporting an entire designated record set on a patient should you be requested to do so. Right now, all that's required under the Cures Act for export is the USCDI. So what is the USCDI? Well, you can look it up. There's a link on this, but you can see there's a lot of different things. Treatment plans and assessments, allergies, procedures. So that would be, procedure notes, things like that. clinical notes, and you've got discharge summaries, H&Ps, procedures, consults, immunizations, lab reports, medications, demographics, all different kinds of things, even provenance, which is over here on this slide over on the right. That means the metadata, who signed it, or who created the information, date, time, things like that. So that kind of provenance data we've never had electronically. We have had it in paper when you signed it and dated a report, but this is for electronic information. So they're requiring not only the report, but who signed it and when and things like that. So the USCDI, again, is the data set that the EHR vendors are working on now to be able to provide through an API should some application ask for it. The again, what happens in October of this year is that the USCDI is no longer just the basis for what you'd have to export. You'd have to export everything in the designated record set as well. So what happens if you are thinking there's an issue with fulfilling the patient's access request, or anyone else that is trying to get patient information on a legitimate basis that is covered by the information blocking rules? There are 8 exceptions to giving the information up. You wouldn't be an information blocker if you properly used, or what I call invoked, one of the 8 exceptions. Here they are. There's an exception for preventing harm. Obviously, if you're going to give the information out, it would there's a potential for harm, and that it's well laid out how you would figure that out. It's already part of different laws, so it's not unknown how this is being done. So there is a preventing harm exception you could invoke and not release the information. There's a privacy exception. So if something's wrong with the privacy of the request or the requestor, there's a security exception. If the system is going to cause damage or slow down the EHR or whatever system you're getting the information from, the security exception could be applied. And feasibility exception, meaning they're asking for something you can't do. Health IT performance, kind of the same, kind of overlaps with security in that you can't hammer the host system performance to try to give up information that's being requested because it somehow would impact the performance of the host system. The licensing exception, the cost exception, those 2 exceptions down on the bottom are really probably more for the vendors. It's not a cost exception. Really, what they're trying to do there is say that you cannot, the vendors cannot charge an unreasonable amount of money to allow these kinds of activities to happen. So, excuse me, there is a cost exception. And the content and manner exception, which will probably be used fairly often, means, again, it's not infeasible to give you the information, but the content or the manner with which you're asking for the information is something that we can't serve up to you. So, you're asking for it in XYZ format, and we can only do PDF. So that's where you might invoke that kind of exception. Now, invoking these exceptions is not as easy as you might think. For each exception, there are reasonable and necessary practices and conditions to meet. And each exception has a different number of conditions that you have to meet and that you can pick from. Some have 2. So this is the privacy exception. You can see on the left, it tells you what the exception name is. The middle is the object of the exception, reasonable and necessary practices, and then the conditions of which you have to meet at least one of those is what you would have to invoke the privacy exception. So if you're going to invoke an information blocking exception, you're going to have to record why and what you're invoking on. And later you may, if If you're invoking an exception later, you might revoke the exception if the person asking for the information cured whatever problem it was you were trying to address. All of that will have to be kept in records. You can certainly make spreadsheets. I figured out how to automate it, but there's probably not a lot of automation out there for this right now. Maybe there'll be a little more as time goes forward. Timing for patient access to the USCDI and then beyond. Okay, so remember, HIPAA we think is going to go from 30 days, a maximum of 60, because you have another 30-day exception, to hand off information. They're likely going to cut that to 15 days, plus another 15, but still 15 days, you have a good reason not to give up the electronic information. Remember, this is all electronic information. HIPAA will be 15 days whether it's electronic or not, but Cures Act is electronic information. And how long do you have then to say you're going to issue an information blocking exception? Well, there really isn't a number that they've published, except for, I think it's content and manner. I think you have 10 days to invoke that exception. One of the exceptions has 10-day window. The rest is kind of an imprecise number. It basically is going to line up with HIPAA then. So either you're going to give the information up in time to meet the HIPAA deadline, or you're going to invoke an information blocking exception, something like that. Again, until people get in there and start doing their policies and we figure it out exactly, I don't know. But I would suggest you're going to want to invoke the information blocking exception before the end of the time frame that HIPAA mandates to give them the information. So again, lots of things up in the wind and changing, implementations happening on the Cures Act. Be talking to your EHR vendors, figure out, the patients are going to go to the portal for some information, but if they want the entire chart, or when are they going to use the APIs? How is that going to be published? Where does that access come from? Does it come from the portal? Do they have to log in the portal first? There's any number of things that, how would that work? Would an application ingest from the directory that you publish the API, and it goes directly and uses the API to call for an export and then get it back to their product? That all of that has to be worked out. So talk to your vendors. I mean, there's no doubt Epic and Cerner are well on it. I'm sure the others are too, but those two I've actually spoken to about it, and I know that they've been working very hard for quite some time on it. What I don't know is exactly how it's going to work. But determine which areas of your organization have to deal with what elements are we talking about. People making the APIs and working with the EHR vendors, not the ones that are necessarily going to be doing patient education. So, and release information and HIM still got big roles here. And how are you going to know which exceptions you're invoking and not, things like that. So keep doing what you're doing, but watch the media, watch for announcements for ONC, CMS, OCR, and let's try to make sure that, we all will learn as we go. And maybe next year, when we do this kind of presentation, we'll have more hard facts with how folks are meeting their compliance to talk about. But in the meantime, as always, feel free to contact me. Glad to, help you any way that I might. So let's take a look here and see if we have chat questions. Good. Well, thank you. Glad to be here. I don't see any questions in chat. Let's open it up. Oh, wait, there may be some.
Thank you so much, Kelly, for your very, very great information. Attendants, if you have any questions, feel free to put on the chat or let Kelly know in the email address. Would that be okay, Kelly?
Yeah, we can just ask. If anybody wants to ask, you can, or you
Yeah.
can chat.
There would be one question for myself.
Okay.
According to the information blocking rule, if there are a patient portal in that clinics, should all the elements in the USCDI be included in that patient portal?
You've asked such a good question. I'm glad you asked that question.
Thank
Wish I knew, wish I knew the answer. So there's no. The patient portal is never mentioned in the rules that I saw. And so whether there's an expectation that you're going to use the patient portal and get all the USCDI out, I don't know. It seems intuitive to me that it would be, but again, we're just going to have to see how the vendors express it. I mean, if you're using Ethics Portal, you would think that you would get the USCDI out of the portal, especially if they're having to prepare that report in case somebody asks via API. But if you were using a third party portal, that might be less likely that you would get the entire USCDI. So I don't really know. It's going to be situational, and you have to talk to the vendor.
thank you. Another questions for the part of the HIPAA privacy.
Okay.
Uh, there are some company that we all have heard about, the medical record retrieval company.
Yep.
Some of that company have a little bit more tricky request form where require the patient to sign something at the lawyer office or somewhere that the patient did not recall and put the date of the medical record that they want to request later. Will that be considered as a blanket authorization, or that could?
Yes. So
Oh,
that's not really that I know of addressed, and I don't think so. I don't think so. So you under 42 CFR, the substance abuse rules, you can now release information without a specific authorization for each release. But HIPAA didn't say anything like that. That's for the substance abuse rules that had a specific rule saying each request, had to have a specific authorization from the patient. They've gotten rid of that, but the in HIPAA, nothing's really changed, and we're going to continue to have the law offices try to find ways around paying, uh, and they will continue to make requests that are not really applicable under the information blocking rules. Again, they'll probably want to request certified copies of the records, which is not what you're really going to get through the APIs. And if a patient directs copies, not really certified copies. So there's going to be a rub still between attorneys and release of information, but no, there's nothing in the rules for HIPAA that I know of that would cause something like that to be a blanket authorization.
thank you. Anyone else have any questions?
Looks like we're about done.
Should we wrap it up, or
Yeah,
again, yeah, if you all have the question that you may think about this later, feel free to email Kelly for more information and more answers. Thank you so much, Kelly, and thank you to you all for attending our webinar. This is a very great topic.
thank you so much for having me. I love it out there, and give you best wishes from Florida.
Thank you. Come to Oregon sometime.
Well, I'm get out there as soon as I can. I promise you that.
Yeah, the weather getting nice.
I know it is. We know it is. My wife and Oregon is our favorite state to visit. So there you go.
Oh,
Be
thank you.
careful.
Yeah. Yeah. Thank you, you all. So we are ended our webinar for today, and I wish you all have a great weekend. Thank
Say
you.